Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video. Now this is a video that I hope all of you watch till the end, and it's in some important messaging that I'm going to provide during the course of this video. Now I have sped this video up because I wanted to ensure that it's no longer than 15 minutes, because I'm also going to be posting on LinkedIn for my colleagues, because the messaging is also appropriate for them. Now, this is of a patient who did actually see me many years ago. I think it's 2019, memory serves me correct. And she developed some more symptoms recently, and she did consider booking with myself again, but because the procedure was quite straightforward at the time, and because obviously I do charge a lot more than most people, she thought, well, the local pharmacy where she's at is offering the service, so let's just pop in there. So she visited her local pharmacist and was initially attempted treatment at the first appointment, and they weren't able to remove this hardened keratin that I'm removing. So this is not wax, this is hardened keratin. Acetous drops, and then she went back and saw the same person, and it then became apparent to the patient that the individual that was treating them didn't really know what they were doing. And it was when that individual advised the patient that she is, so I know it was a female, because the patient did mention, when she mentioned to the patient, I'm just going to go call the pharmacist for some help, the patient queried, because the patient was under the impression this individual was the pharmacist, and then so the patient asked the individual, so what's your job role? And it was then that this individual told the patient that she's a sales assistant. And you can imagine the shock and horror upon my patient's face. And so this individual called a pharmacist, and no disrespect to pharmacists, but a pharmacist is not an ear specialist. So the pharmacist came, and the patient just kept remembering the word membrane. They were just saying the word membrane, which I'm assuming they're referring to tympanic membrane, which wasn't visible because we had this hard blocked wax. So I'm suspecting they thought that this blockage was possibly the tympanic membrane. And at that point, the patient says she's leaving, and did actually advise the pharmacist and the sales assistant that they're going to come visit me. And apparently the pharmacist and the sales assistant both know of me. So if you're watching this, please do carry on, because I think it's important that you do watch this. Now, so the patient attended, and she kind of explained what happened. I think she was almost slightly embarrassed that she visited the pharmacy to have the procedure performed. Now, should pharmacists perform earwax removal? If you're just a pharmacist without any specialist training in ears, then no, certainly not. We've trained pharmacists in the past, but we've trained prescribing pharmacists, and these prescribing pharmacists are pharmacists who are allowed to prescribe medication for ear pathologies. So naturally, I assume that all prescribing pharmacists would be highly trained in ears. And while some of these prescribing pharmacists were obviously highly trained in ears and they've had a lot of experience, some prescribing pharmacists actually didn't know anything about the ear. And then I queried, well, how can you prescribe medication? And then they explained the training and how poor it is. I'm trying to think of a more diplomatic word. And it was at that stage that, because it's not possible for me to be able to decipher which prescribing pharmacist has been appropriately trained and which hasn't, because the training doesn't appear to be universal. It's not a standardized approach, apparently. So I no longer train pharmacists or prescribing pharmacists. Well, I don't train pharmacists from the beginning, but we don't train prescribing pharmacists anymore, because I just don't know who is adequately trained or not. So that initial keratin, it was embedded. You could see where the suction probe had kind of gone into it. So it's been lodged in, and the patient did feel during the procedure, because it was very painful, that it kind of somewhat made it worse. And I initially used a suction probe, and it was very apparent that wasn't going to be removed. So that needed to be removed manually. And again, if you're an ear care specialist and you weren't able to use manual instruments to remove that, then you've got to question whether you should be seeing patients. And this is the exact reason why I started my campaign last year. It's because this is inevitable. This is what was going to happen. Upon removal of that keratin, now I kind of assumed there was a bit of a possible infection behind the ear. Now this patient didn't present with any ear pain. There's no discharge leaking out the ear, and that's because this discharge is trapped behind that hardened keratin that I removed initially. And it was quite thick and purulent, so it's stuck to the eardrum. This patient's symptoms were really a blocked ear, and they also experienced a lot of itchiness. So although when I first examined this patient's ear, there was, some people may have thought it was wax, it wasn't, it was hardened keratin, but I could see a bit of a dampness on top, so I assumed there might be some infection. So upon removal of that, we can obviously now see that the medial aspect of the ear canal was occluded with this thick, purulent arterial discharge. There's granulation tissue on the left that was hidden until I removed some of the discharge. So if you're an ear care specialist and you weren't able to use manual instruments, because suction wouldn't have worked with this patient, and what some specialists might have asked the patient to do is go away and put more and more drops in, which clearly we don't want to be doing in this ear, because they've got a middle ear cholesteatoma by the looks of it. And I know some specialists would have maybe reverted to irrigation, and this is why I don't use irrigation, because I just don't know what's behind the ear, and we certainly don't want any water in this patient's ear. So I know sometimes I get a lot of comments about why don't I use irrigation. Well, this is why. Now, people want to use irrigation, fine, that's up to them, but this is my reason for not using it. You can tell that I'm a bit annoyed, because this could have been, anyone who's watching this video, this could have been your ear or a loved one's. It could be a friend or a family member. And it's scandalous. It's absolutely reckless, irresponsible, and scandalous that there's non-clinicians performing earwax removal in the UK. It's also scandalous that there's clinicians with no previous ear experience attending 1 or 2 day courses performing earwax removal, because this is what could present. Now, this is a potentially very serious and even potentially life-threatening condition, which is a middle ear canal cholesteatoma, and I'll explain what that is at the moment. So, I know I'm going to get a lot of hatred from certain companies, because I have called a particular company out about this, and I'm readdressing the issue, because I think, although I've seen many cases of patients who are seen by non-clinicians in particular, and yes, there's been trauma to the ear. Patients have had really bad experiences to the point where I've got another one to upload actually in the next few days. Really bad experiences, which has really made them nervous and tentative. And there's been, some misdiagnosis, but nothing to this extent where, this is really, really serious now, what this patient's presented with. So they have got what we call a middle ear cholesteatoma. So what is a cholesteatoma? Now, a cholesteatoma is a dead skin cyst that forms normally in the posterior superior quadrant of the eardrum. So in the case of this patient's right ear, it's the top left. And that's because the posterior superior quadrant of the eardrum is more prone to getting retracted if there's negative middle ear pressure. So the cavity behind the middle ear should be air-filled, and the air pressure should be equal to the air pressure in the atmosphere, so in the ear canal. When the air pressure is equal, that's when your eardrum is at its most mobile. And there's a tube called the eustachian tube that connects the middle ear to the back of the nose, the nasopharynx. And that tube is responsible for equalizing the middle ear pressure. And it also acts like a drainage pipe, so any fluid that may accumulate in the middle ear, it can drain out the eustachian tube. However, if that eustachian tube gets blocked or fails to open at the back of the nose typically, it creates a vacuum. There's no air in the middle ear, and it causes a kind of a cupping suction effect. So the eardrum gets pulled inwards, and because the posterior superior quadrant of the eardrum is most elastic, it's more prone to getting sucked in. So when that area of the eardrum is sucked in, it could also be the attic, the pars flacidus, or the top part of the eardrum. When that area of the eardrum is sucked in, skin that would normally migrate off the eardrum towards the entrance of the ear canal migrates into that pocket, and it gets trapped and it forms into a cyst. And this cyst is self-growing, and it continues to grow. And when it grows, it releases proteolytic lysosomal enzymes, which are destructive enzymes. They literally chew up flesh, bone, nerve, whatever is in its way. Then you have bacterial involvement because it gets infected, and these bacteria also release proteolytic enzymes, which continue to digest and chew away and eat away at neighbouring flesh, bone, nerves, whatever it may be. So it's a locally destructive dead skin cyst that's self-growing. Now the ear is just below the brain. There's a piece of bone called the tegmen tympani, which separates the middle ear from the intercranial compartment where the brain sits. So this cholesteatoma can grow upwards towards the brain. It can erode the tegmen tympani. It can infect the meninges. It can lead to meningitis or brain abscess, which potentially could become fatal. This dead skin cyst can grow posteriorly into the mastoid bone, which is the bone behind your ear. It can grow inwards into the middle ear. It can erode all the three bones, the ossicles. It can also erode the chorda tympani, which is the nerve of taste, which just runs behind the eardrum, up against the inside of the hammer bone. It can erode the facial nerve, which is adjacent to the stapes foot plate, so patients can get facial palsy. Cholesteatomas are normally in the back part, middle ear cholesteatomas, but they can on the back part of the ear canal. But if they grow anteriorly, it can affect your parotid gland. It can affect your TMJ, so temporomandibular jaw joint. So this is not, this is why I'm getting so annoyed and frustrated. And to those companies that are training these non-professionals, you are, I was going to say solely responsible, but not only are you responsible, but to these non-clinicians who feel it's appropriate for them to perform these procedures, you are, of course, also, you may have been sold a dream by these companies, but you are also, you should have enough awareness that you shouldn't be doing these procedures because you just don't know what's behind the wax. And if you can't remove the wax, which a lot of the time you can't because I see a lot of the patients, and if they do remove it, they come extremely traumatized. There's potential life-threatening conditions that can occur in the ear, which you're not trained to even, I don't even believe you even get any training on a cholesteatoma. If you do, it's just a quick 10-second slide maybe because you're getting trained in 1 or 2 days. And if you're a pharmacist and you're sending your sales assistants on courses to get earwax removal trained, you should be ashamed. You may think it's additional revenue for your business, but this could be your, as I said at the beginning of the video, this could be your ear. It could be one of your family members, close friends. Like, it's just ridiculous. I wouldn't start performing any physiotherapy or performing dental procedures. It's not my line of work. And if I do want to perform dental procedures or become a chiropractician or a podiatrist, I sure wouldn't go on a 1 or 2 day course. I would have a career change and I would study the proper way. So I think, I know other colleagues of mine have had similar instances where there's been a serious pathology behind the ear, behind the wax or dead skin that's gone undiagnosed because the clinician weren't able to remove it. But this is my real first serious one, and it's just not right. And obviously the patient was extremely annoyed, and they asked what can be done, and I says, well, it's not regulated, unfortunately, so I really don't know what you can do. Now, even if an audiologist or a trained clinical, suitably qualified clinical ear care specialist wasn't able to remove all that discharge that I've removed off the eardrum and the medial canal wall, they should have been able to remove that keratin, and they would have seen that the ear is infected. That would have meant a referral to their GP at the very least. But this patient was actually invited back on a third appointment, but by the pharmacy, which is local, not too far from me. So if you're watching this, please do reconsider offering the service to your patients. You can see that retraction full of granulation tissue, which is weeping. Well, I hope I'm going to say enjoyed the video, but hope you understand the message behind the video. Bye.